Okay. Pain is a protective mechanism. That means that there is tissue damage. So something should be done for that injury or for that injury. Okay, so it's a protective mechanism. So you know that we have two major types of pain that include fast pain and slow pain. So one point is this one. Fast pain is felt in 0.1 second, but slow pain begins only after 1 second and then increases slowly. So these are other names for fast pain, like sharp, pricking, acute. And these are other names.
Because there's no point.
Point.
So,
That's what
now, okay. So these are other names for fast pain, and these are other names for slow pain. So fast pain and slow pain, okay? Receptors for pain are called nociceptors. So nociceptors are receptors that detect tissue injury. Sometimes potential tissue injury, not real tissue injury, right? So they are free nerve endings. So remember from touch position, right? That we have 6 different types of receptors in this skin.
Yes.
Mycelium, Pacinian corpuscle, Porphyrin, brachial disc, hair receptors, and free nerve endings. So, some of the free nerve endings are responsible for touch, pressure, vibration,
Yes.
right? But there are also other free nerve endings that are responsible for pain, like this. We call them nociceptors. Other free nerve endings are important for each, and others for tickle. Right? And also there are other free nerve endings that are responsible for temperature, both cold and heat. So, free nerve endings are important for touch, pressure, vibration, tickle, age, temperature, pain. So they are different actually, different in function, but they are the same in structure. They are free and they don't have any specific structure at the tip of the nerve. Okay? So we have just branching of a nerve fiber like this. At the tip of the nerve, it doesn't have anything. We don't have anything. Right?
Yes.
But if we compare this with a mycelial corpuscle, it's like this. So there is something here. Inside the capsule, we have some Schwann cells. And between these Schwann cells, we have a nerve fiber that goes this way. So it's a mycelial corpuscle. Right? But free nerve endings are free. Right? The tip doesn't have anything. But all of these free nerve endings are the same in structure, but their function is different. Some of them are important for age, others for tickle, others for pain, others for, I don't know, cold, heat, and so on.
Right. We're talking about the chili corpuscle.
The Pacinian corpuscle
Like this?
has a capsule, like this. But instead of having Schwann cells inside, they have fluid,
Yes.
right? So it has a nerve that enters the capsule, so we have several layers of capsule. Inside the capsule, we have fluid, right? And it's myelinated. ADR.
Except
Remember?
Yes.
Yes, except the portion of the fluid that's covered by fluid, it's not myelinated.
Yeah.
Yes.
The teeth is not myelinated. So,
I speak out a question. Is it especially important to memorize the structures of each corpuscle, the difference between Pacini and Meissner, or is it not very important? They're quite confusing.
we should know the structure, actually, but not details. I mean, actually, I don't give you any detail about the structure. I don't remember. The only thing that I mentioned is that this one is filled up some Schwann cells, but this one is filled with fluid. But I specifically explained about the function of the Pacinian corpuscle, right? Mechanosensitive sodium channels in the tip, voltage sensitive channels in the granule, right? So they are important actually. So, free nerve endings are nociceptors, some of them. They are found in superficial layers of the skin and in some other tissues. So these tissues have abundant free nerve endings, pain receptors, preosteum that covers the body, right? Arterial wall, joint surface, fats. What is it? Fats?
Pulse.
Yeah, what is it?
Tapes.
بالعربي
Where do we have this? Pulse. Where do we have this? Tentorium.
It's cranial.
Inside the cranium, yeah.
Yeah.
So, pulse is between hemispheres. So you know that we have duromater, parameter, artery. So there are some layers that cover the brain, right?
Yes.
So all of these layers go between the hemispheres. So they make faults between the hemispheres. Another one goes between the cerebellum and cerebellum. Okay, we call that tentorium. In the tentorium, and fourth, we have abundant nociceptors. So any damage here is very painful, right? Damage to the preosteum is painful because we have abundant nociceptors. Nociceptors are non-adaptive. Remember, receptors are either slowly adapting or rapidly adapting. Adaptation means decreasing the firing rate in response to constant stimulation. So when you have constant pressure, some receptors adapt very fast, like Pacini codes.
hair or hair receptors.
Hair receptors. Other receptors adapt very slowly, like Merkel, Ruffinian, right? Okay, so generally, receptors are slowly adapting or rapidly adapting. Pain receptors are slowly adapting, right? Generally. But sometimes we call them non-adapting because instead of reduction of firing rate, they increase their firing rate when we have constant stimulation. So stimulation in pain is injury. So you have injury, it's constant, right? The injury is constant, but the firing rate doesn't decline, doesn't decrease.
Increase.
Sometimes it increases,
Hyperglycia.
right? What do we call that? I mean, this increase? No.
Hyperreduction.
Increasing firing rate. We call this sensitization. So receptors show adaptation, which means decreasing firing rate, or sensitization, increasing firing rate. So two clinical features related to sensitization of nociceptors include hyperalgesia, which means increasing pain perception in response to constant injury. So there is an injury, you have a wound in your skin, okay? And so it's painful, okay, we know that. And suddenly you also burn your wound, okay? So this burning feels more painful than burning that happens in the intact skin, right? We call this hyperalgesia, so exaggerated pain, because there was an injury before. We call this hyperalgesia. Another condition is allodynia. Which means perception of pain in response to non-painful stimulation. I gave you several examples. One is the sunburn in your skin. You go to the beach, you have sunburn. Okay, sunburn is not painful when you don't touch it. But if you touch it, it's painful. Touch in the normal skin is not painful. But here it's painful. What does it show? It shows that nociceptors are sensitized. They are stimulated even by non-painful stimulation. Right? Another condition is artery rheumatoid. So the patient feels pain in the knee in the morning, especially when they come out of the bed. So moving the knee shouldn't be painful, but in this patient it's painful because there is inflammation in it, right? So hyperalgesia and allodynia are two syndromes that show pain receptors are non-adaptable. They sometimes increase their fire. So, actually, this figure shows different type of channels and receptors in the membrane of this nociceptor. So remember, I told you before about Pacinian corpus, right? I told you that there is a capsule here, it's myelin, right? This one is myelin. In the tip, we have sodium channels that they are opened by pressure, mechanical pressure opens the channel, sodium goes into the cell. We have a potential change that is called receptor potential. Receptor potential activates some other sodium channels here that are voltage sensitive. They cause action potential, right? So this is the mechanism for activation of Pacinian corpus. Okay, how free nerve ending is activated when there is injury? How a free nerve ending is activated when there is injury? So this is the mechanism for activation of Pacinian corpus when we have pressure. What about injury? How injury activates this?
Transmission.
Okay, actually, in the membrane of this free nerve ending, we have several types of channels. We don't have sodium channel like this, mechanical sodium channel. We have other type of channels. Some of them are called TRPN8. This one is activated by cold. We have ATP channels. We have TRPA1. It's activated by mechanical energy. We have acid sensing ion channel, ASIC. We have TRPV1, transient receptor potential 1. V stands for vanillin. Okay? So, different type of channels are expressed in the membrane of free nerve endings, and they can detect different type of pain. Some of them are thermal pain, others are mechanical pain, others are sensitive to ATP. ATP is released when there is injury. So injury causes rupture of the cell. Inside the cell we have ATP, so ATP is released, so it can activate this channel. Activation of this channel activates this nociceptor. Action potential is made using this way. Right? And so on. So, different channels are present in the nociceptor. Different type of nociceptors. So we have 4 types. So mechanical, thermal, chemical. The other name is polymodal, so it should be here. Okay? Another name for chemical channel is, chemical nociceptor is polymodal. So, the first type is silent nociceptor. Mechanical is sensitive to mechanical injury. Mechanical injury. Cut in the skin, pressure, punching. So mechanical. Thermal is sensitive to hot and cold. Right? Extreme hot, extreme cold. We have chemical nociceptors that are sensitive to some type of chemical substances like radical, histamine, acids, serotonin, potassium, enzyme, photolipids. Other chemicals like prostaglandins and substance P don't activate nociceptors directly, but they can increase the sensitivity of the nociceptors to other chemicals. Right? So, chemical nociceptors are also activated by mechanical and thermal stimulation. So that's why we call them also polymodal. So they're activated specifically by chemicals, but also by mechanical and thermal. Fourth type is silent. They are not activated by a painful stimulation in natural state. They are pain receptors. When there is injury, they are not activated. But in some conditions, they are active. For example, when we have inflammation, okay, you know inflammation, right? So when we have increasing blood flow, when we have redness in the skin, in the tissue, when we have a movement of fluid out of the blood, right? So we have inflammation. Inflammation activates silent nociceptors gradually. After that, they become sensitive to any other type of stimulation. One mechanism for hyperalgesia and allodynia, one probable mechanism is activation of silent nociceptors. Right? So, let's see the fibers. Okay, fibers. Remember, from touch position and vibration, that 6 different receptors, Pacinian, so 5 of them, Pacinian, Meissner, Merkel, Ruffini, hair receptors, all use what? A-beta. Right? So, what about
Nerve
nerve
C.
First, A, delta, and
C.
right? So here, we have 4 types of nociceptors, thermal, mechanical, polymodal, silent. 2 of them, mechanical and thermal, use A delta fibers, the myelinated fibers. 2 others use C fibers, polymodal and silent. All of them are free nerve endings, but they use different fibers. Which one is faster?
A
A delta.
This one is a slow one. So you may have a single injury in the skin, but this injury activates several nociceptors. Some of them are associated with A delta fibers, others are associated with C fibers. So we have 2 signals that is sent to the spinal cord. The first one goes very fast through the A delta fiber. The second one goes slowly through the C fibers. So we may have one injury, but we feel 2 pains. Fast pain, slow pain. First pain, second pain. The first pain is short, right? But the second pain actually is smaller, but is more prolonged. So sharp and short, but slower and weaker, right? So this is conveyed by C fiber, this one is through the A delta.
Is it always this condition that we have first pain and second pain?
Usually we have this. So for example, you have a pinprick. So
Yes.
you hit the needle to your skin. First,
Sharp
you
pain.
feel this sharp pain,
And then from
but after that,
from
you can see that the pain continues. Okay? And you will have some swelling of the skin and redness also. So around the region you have hyperalgesia.
The second pain?
So we have the second pain also. So first pain, second. Okay. So you know the nociceptors, free nerve endings. You know the fibers, A delta, C delta.
Yes.
What about the tract? Spinal tract. Spinal thalamic tract. So generally we have 2 tracts, DCML and collateral. DCML was for position, fine touch, graded pressure, position, vibration, movement on the skin, right? Anterolateral was for pain, temperature, tickle, itch, sexual sensation,
Tickle.
crude touch, crude pressure.
Yeah.
You know crude.
Yes.
Yes.
Tough.
Good. So, now we are talking about the pain. It's anterolateral system. But anterolateral system has two components. Right? So let's see.
A delta and C fibers.
Pain fibers that are myelinated, A delta fibers, enter the spinal cord. They terminate in layer 1.
Lamina one?
Lamina
Yes.
1, yeah. Layer 1 or lamina 1. So we call them rexed lamina, right?
Raise
Yes.
lamina.
Yeah. Rexed
Exit lamina.
lamina 1 to 10. Okay, so lamina 1. They terminate in lamina 1. They activate second order neuron. The second order neuron starts from here, sends the fibers in the anterior commissure to the opposite side. They go to the lateral part of the anterolateral system, or let's say lateral spinothalamic tract. Right? So we call this neospinothalamic. So lateral anterolateral system, lateral spinothalamic, neospinothalamic. They are all the same. Right? So they are responsible for fast pain. Why? Because this pain is coming from a delta fiber. Fast pain, right? C fibers that carry slow pain
Slow pain.
enter the spinal cord, terminate in layer 2 and 3.
And 5.
Some of them go directly to layer 5.
5.
Those that terminate in layer 2 and 3 activate other neurons that come to layer 5. So the final layer is layer 5. From here we have the second order neuron that crosses the midline, enters the ventral part of the anterolateral system. So ventral spinal thalamic. It's also called medial spinal thalamic. So neurospinal thalamic tract for fast pain, spinal thalamic tract for slow. Here, in layer 1 and layer 5, between the incoming fiber and the outgoing fiber, we have a synapse. And this synapse, the neurotransmitter which is released is glutamate. So glutamate is released both from the ending of A delta fibers and C. But C fibers also release substance P, which is a neuropeptide. And you know that neuropeptides are slower but have more
Longer
action and prolonged action. So C fibers release substance P to increase the feeling of pain. Right? To increase the feeling and they cause prolonged feeling. Right? So what else? Okay, everything is okay here.
Doctor, if
Yeah.
you bring a question on this, how would it be? You give me the pathway?
Everything. For example, which one is not related to fast pain? A delta fibers. B. Glutamate. C. Neurons in lamina 5. D. Ventral posterior nucleus
Which one is involved or not involved?
is not involved.
Not involved.
Glutamate.
Lamina 5.
Lamina 5 are not involved with fast pain. So you should know every details, right?
What about laminar rexin? Should we memorize each one and memorize?
Actually, I don't want to know. I don't want you to know all of these, but this one is important. This one and this one.
Okay.
1, 2, 3, 5.
Okay.
Okay. Everything is clear here?
Yes.
Let's go on. Okay. Nociceptors, fibers, tracts,
Pathways.
termination. Good. Okay. In your spinal thalamic tract, which carries fast pain. That question?
Yes. But there was a third track which I noticed when I was reading the files that it doesn't have its own, slide or section, but it was explained. It's called the
Archie.
Yes, archie.
Archie is spinal.
Archispinal thalamic, and it was from 2, 5, and 7. But yes, it's
Yeah. Actually, it was not the focus of this session and this. Actually, I put it in the slide and in the notes, but only to know that about that.
Oh, so
Okay,
it's not-
so it's not included in your exam. Okay, so spinal thalamic is another tract, a third tract, which is important for pain, but because we have 2 more important tracts, spinal thalamic, spinal thalamic.
Exclude one.
Yeah, this one is minimal actually in function, but sometimes those 2 tracts are destroyed. I mean, anterolateral systems, right? And the archiospinothalamic tract becomes more important. So they become more active, more sensitized, and it carries pain signals strongly. So in these conditions, it becomes more important, right? Okay, so termination point. Neurospinothalamic tract mainly goes to thalamus. So you can see the second order neuron from here. It passes the brainstem, reaches the thalamus, and in the ventrobasal complex of the thalamus. Ventrobasal complex. You know, it has 2 parts, VPL and VPE.
I nucleus.
VPL or I, so I usually don't mention this. Okay, because this one is more important. So ventral posterior lateral for body, ventral posterior medial for face. Right? So sharp pain or fast pain reaches here. VPL or VPM. And from here they go to cortex. Each area is what the sensory area 1, similar to touch. Right? But a few fibers go to reticular areas. Right? But paliospinothalamic tract, it's different. A few fibers go to thalamus, but more of them go to reticular formation. So in thalamus, they don't go to VPL or VPM. They mainly go to intralaminar nuclei. Intralaminar nuclei, which include paraventricular, centromedian, central lateral. So different nuclei in thalamus. We call them non-specific. You know this?
Yes.
Specific nuclei, non-specific nuclei. But most of the fibers go to the reticular formation. Which areas? Reticular formation of medulla and pons. So we call this part spinal reticular tract. So it's part of the paliospinothalamic tract, right? Other fibers go to periaqueductal gray region, PAG. We call it the spinal mesencephalic tract. Tectal areas, spinal tectal tract. Right? So all of them are part of the paliospinothalamic tract. Some of them go to reticular formation of pons and medulla. Others go to tectum. Others go to PAG. Right? So most of them go to reticular formation. A few of them go to thalamus. Thalamus. Right? Got it? Simple.
What about the gray region and the tactical area?
Preaqueductal gray region? You mean PAG?
Yes.
What is it?
Do they also go to the pre-vacuum? This one.
This one.
Yes.
So some of the fibers in the paliospinothalamic tract and in the preaqueductal gray region. So they start from nociceptors, they go up through the spinothalamic tract, they reach brain, but fibers go to different targets. Some go to thalamus, others go to PAG, others go to reticular formation, others go to tectal areas, right? For different purposes. You'll see that. So, Medial-spinothalamic tract reaches the cortex. Halio-spinothalamic tract mainly goes to reticular formation, thalamus. Some of them also go from thalamus to cortex. Okay, a few of them. What is the importance of cortex for pain? I told you before that if you remove somatosensory area 1, what happens to the patient? The patient cannot feel touch, cannot recognize vibration, cannot judge about the weight of objects, cannot judge about the level of pressure, right? Cannot even recognize the shape of objects held in the And you know that there was some metastasis, you know, metastasis? I mean, the cells were propagated in the body. The tumor was here, but after a while, it sends the cells all over the body. So the liver is actually cancerous now. Stomach, the brain, everywhere in the body we have cancer. So you know that the patient is dying. But he or she feels pain, severe pain. We gave everything. Morphine, I don't know, any painkiller, but they were not actually happy. Okay? So you know that the patient is going to die in 2 months or 3 months. And you want to do something to relieve the pain. Right? So one strategy is to cut the spinal cord in the anterolateral quadrant in order to cut the spinothalamic tract. So cordotomy in thoracic region usually happens, done to actually interrupt pain signals from the lower part of the body to the brain. The other condition is to destroy nuclei in the thalamus that are responsible for pain, especially intralaminar nuclei. Parafascicular, centromedian, central-lateral. So you can destroy those nuclei. So this way you can stop pain signal from going upward to the cortex. Right? So cauterization of the specific pain areas in the intralaminar nuclei and cordotomy are two. Yes?
And cordotomy, we should destroy the opposite side. The opposite lateral side.
Yeah. We do this on the opposite side. Why?
Because it's attending to it's cross. It's made cross.
Yeah. So the cancer is in the right leg, pain signals come to the spinal cord.
Cross to the left
Yeah, the
side.
second order neuron goes to the opposite side and then goes up. So you cut the opposite side,
Yes.
right?
Doctor, you said in cordotomy,
Yes.
relieves the pain for a few weeks to a few months.
Yeah.
So it comes
Because,
back.
yeah, pain comes back. Why? Because of the archy spinal thalamic tract. So you only cut spinal thalamic tract, the anterolateral quadrants. But archy spinal thalamic tract is more actually widespread in the spinal cord, and it's bilateral. So in the spinal thalamic tract, fibers go to the opposite side and goes up only unilaterally. But archy spinal thalamic tract is bilateral. It enters the spinal cord. Some of them cross, others don't cross. They stay on the same side. So they go from both sides. When this tract is sensitized, then it can carry pain signals to the brain. Okay? So, we have another system in the brain that suppresses the pain. We call that analgesia system. So we have a system for bringing pain information to the brain. We have another system that
Inhibit
is
the pain.
parallel to this one, but goes down from the brain to the spinal cord in order to stop pain signals. Okay, so everything starts from the hypothalamus, periventricular. Neurons go to PAG, periaqueductal gray matter. From here we have some encephalin neurons that go to the nucleus raphe magnus. You know that it releases serotonin, right? So neurons here go down through the brainstem and the spinal cord. They reach the spinal cord at different levels. They activate some interneurons that release enkephalin. These neurons are located in layers 2 and 3. Right? They inhibit the synapse between C fibers and A delta fibers and neurons in the spinal cord. So, this way they can decrease pain, right?
So it's for slow pain. The
Yeah, mainly for slow pain.
spinal column.
Yeah, mainly for slow pain. But also for sharp pain maybe.
So, Doctor, I have a question.
Yeah.
Actually, so the neuron sign, like, go from many receptors to reach the spinal cord or the brain, right?
Actually, I didn't get your question.
Okay, we have like many receptor for pain
Yes.
and sensory.
So we have a spinal cord. So imagine that this one is a cut of the spinal cord. Dorsal horn, ventral, right? So we have C fibers. So the soma is in the DRG, right? Dorsal root ganglion. Peripheral part is in the skin. So these are free nerves, right? Soma is in the DRG. The central one comes to the spinal cord. So in different layers. Layer 1 for A delta fibers, layer 2 and 3 for C fibers, right? From layer 2 and 3 they go to layer 5, right? So imagine that this one is the second order neuron that is activated. They cross the midline, enter the spinal thalamic tract, and go on. Right?
Yeah.
So action potential from here, then. Now, we want to suppress the pain. So the brain sends some serotonergic neurons from nucleus raphe magnus. So they come down, reach here, okay? they activate some. Let me widen this. Right? We need more areas. So they come here, activates an interneuron, which makes synapses to this one and this one. Right? So this red one releases enkephalin.
It's inhibitory in neurotransmission.
Exactly. It's an inhibitory neurotransmitter. It's a neuropeptide. Right? Enkephalin blocks this cell and also this one. So it has presynaptic inhibition, postsynaptic inhibition. So this synapse is blocked. Right? Pain signals come here, but they cannot go up. Pain is suppressed, right? How this works and when this works. So you can think of a soldier in the battlefield, which is shotted, right? At first, during the war, the patient doesn't feel so much pain. Why? Because the emotional state in that situation is very high. Epinephrine, norepinephrine, yeah, everything. So the hypothalamus is also active, right? Hypothalamus is active, so periventricular nuclei is part of the hypothalamus. So this is the origin of this system. So this system is active very strongly. So it can inhibit pain signals. Pain signals come to the spinal cord, but they cannot go up. The patient doesn't feel it. You take the patient to the hospital, emotional state changes. Now the patient feels severe pain.
Sharp pain.
Right? So an analgesia system is not always active. It's only active in some special emotional states. Right? So you can also think of a player, football player, which is injured during the match, during the game. Okay? At first they may not feel so much pain. Okay? But after they come out of the field, they start to feel pain. Right? So, analgesia system. You should know details. Enkephalin neurons here, enkephalin neurons here, serotonin neurons from the wavy magnus, presynaptic, postsynaptic inhibition. Right? So these are important. You have also other nuclei in the brain that suppress pain. So wavy magnus is one of them. We have nucleus paragigantocellulus. We have locus coeruleus, which releases norepinephrine. We have parabrachial nucleus, which releases butyrate. Right? So several nuclei. What is enkephalin?
Internal neuron. Internal neuron for inhibition. Internal neuron for inhibition.
Yeah. So it is released by some interneurons.
I just have a question.
Yeah.
Does the center which initiates the suppression, is it the periventricular nucleus, or no, is it one of the other, which you just said, Raphe Magnus, or
This one.
periventricular? It controls these four.
Yeah.
Oh.
So originate from here, activate this one, and after that we have this execution.
So inhibition in the nucleus raphe is considered preganglionic?
Not preganglionic, presynaptic. Preganglionic actually is something related to autonomic nervous system, sympathetic, parasympathetic. Okay? So we call this presynaptic, postsynaptic.
And in there, the encphalic neuron, it's presynaptic as well?
Yeah, both of them. Presynaptic and postsynaptic.
Okay.
Presynaptic means it blocks the axon terminal of the C fiber. Postsynaptic means it also blocks relay neurons, the second order neurons in the system. Right? Is this mine?
Yes.
Thank you. So, when I ask you something like this, which one is not part of the analgesia system? Ah, encephalinergic neurons in the PH. B. Encephalinergic neurons in the spinal cord. C. Serotonin neurons from the Reiki magnets. D. C fibers in the D origin.
C fibers.
C fibers in the D is not part of the analgesia system. It's part of the pain system. Right? Or I may give another option. Substance P neurotransmitter from C fibers. Not part of the analgesia system. Right? I think it's easy, right?
Yes.
We'll see. Okay. So, sometimes you are injured, you feel pain, and actually, without thinking, you start to do this, okay? You rub your skin. And you really feel relief after the injury. Why? Okay? So it has a physiological basis. How? So, this one, blue one, is a pain fiber from the skin that carries pain signals to the spinal cord, layer 1, 2, and 3, or 5, right? So it activates second order neuron. The second order neurons go to the spinal thalamic tract and goes on, right? When you do massage like this, you activate A beta fibers. Why? Because you are pressing the skin. And there is also vibration. So vibration, pressure, touch, all of them, right? Hair receptors, right? So they use A beta fibers. They come to the spinal cord, go to the dorsal column, and they go out. So they carry touch signals. But here in the spinal cord, there are some collaterals from A beta fibers. They activate some inhibitory interneurons. Inhibitory interneurons inhibit pain neurons, okay, the second order neurons of the pain system. So, touch, pressure, vibration, activate an interneuron. This one inhibits pain neurons. Touch inhibits pain. Vibration inhibits pain. So we call this lateral inhibition. This neuron inhibited this one laterally. Lateral inhibition. Right? Yes. So stimulation of A beta sensory fibers from peripheral tactile receptors can depress transmission of pain signals from the same body. Local lateral inhibition. Got it? Okay. Yeah, yes. So far we have talked about somatic pain. Pain started from the skin, which is the surface of the body. But we also feel pain from internal organs.
Visceral pain.
Visceral pain. For example, we have intestine, we have stomach, we have heart. All of them may be painful, right? So, visceral pain usually needs a large and spread area of stimulation, not a sharp and localized injury. For example, you can have part of the intestine,
Inflamed.
you can cut it totally without any pain. The patient doesn't feel pain. Why? Because nociceptors are very few in the internal organs. So when you cut sharply, only a few of these nociceptors are activated. So the patient cannot feel pain, right? But if you stimulate the intestine in a way that a lot of nociceptors are activated, then the patient can feel pain. How we can stimulate nociceptors in a large area? With this. Ischemia. A patient that has heart attack has myocardial ischemia, so the coronary artery is blocked, right? So the distal area is under the ischemia. Ischemia activates the cells, nociceptors, so the patient feels severe pain, right? Chemical stimulation. The patient may have peptic ulcer in the stomach. You know that acids and pepsin may actually damage the stomach wall, and the patient may feel pain, right? Well, that's spasm. So it's a type of peristaltic movement in the internal organ. So a spasm causes pain. This pain is intermittent. Sometimes they feel pain, some other time relief, right? So we call this cramp. Cramp means intermittent pain, right? Or distension. So in the intestine, you may have a block, like there is a tumor here. The tumor doesn't allow food to go through the intestine. So before the tumor, there is distension of the intestine. Distension is very painful. So the patient feels pain. You give painkiller, but it doesn't work because the tumor doesn't allow passage of the food. And over distension becomes higher and higher, more and more. Right? Stretching of the connective tissue that surrounds the viscus. For example, you can imagine the brain. So it's suspended in the CSF inside the skull. Right? So the connective tissue that actually hangs the brain inside the skull actually has several nociceptors. So you know LP, lumbar puncture, right? So this patient actually, so you did lumbar puncture for this patient, you draw CSF. So the level of the CSF in the brain decreases. So the brain was suspended in the CSF. Now the CSF level goes down, so the brain also goes down. So the connective tissue is stretched, right? So the patient feels pain because of this stretch. So that's why we suggest the patient to stay lying after the LP and not sitting or standing because it causes pain, right? So, ischemia, chemical stimulation, spasm, over distension, and stretching of the connective tissue or some stimulation for visceral pain. You have also insensitive visceral, like the parenchyma of the liver or lower of the lung, the brain itself. But visceral pain is not sensed in the exact organ that is painful.
Layer of skin.
So it is referred to an area in the cervix. Right? So a heart attack is not felt in the heart. It's felt in the internal aspect of the left arm or the neck. So pain from heart is referred to left side. We call this referred pain. Pain from a stomach, from the inside of the body, is referred to the epigastric area in the skin. So the skin is painful. Right? Referred pain. So this is a map of referred pain. So what is the mechanism for this referred pain? Why we have referred pain? So let me first talk about this one and then after. Okay. So spinal cord, dorsal cord, right? This one, these are fibers that are coming from the internal organ. So imagine that this one is from kidney. Okay? So they bring visceral pain to the spinal cord. So in the spinal cord, they terminate on the second order neurons. The second order neurons carry the pain signals to the brain. But the same population of neurons also receive pain signals from the skin nerves. So the skin doesn't have any injury, right? Injury is in the visceral organ.
So,
Pain signals come here. They go through the same population of neurons that also carry pain signals from the skin. So the signals reach the brain. So the brain feels the pain, right? But the brain doesn't have any awareness of the internal organ. The brain is only aware of the skin and the surface. So the pain that is carried through this nerve, this neuron, can be started from here or here. But the brain usually attributes the pain to the
Skin
skin.
nerve.
Why? Because the brain is not aware of that.
Because what?
The brain is not aware of that. The brain doesn't know anything about the internal organs,
Okay.
right? So it only understands this one. So there may be a kidney stone. It's painful, but the patient feels the pain in the scrotum. Why? The brain doesn't know the presence of the kidney. The pain fibers come here. They terminate on the same neurons that carry pain signals from the scrotum. Right? So the patient feels pain in the scrotum, but there is nothing wrong with the scrotum. Right? That's it?
Is that why if the brain acknowledges the organs, they will get destroyed?
Again?
If the brain acknowledges the organ, it will get destroyed.
Will it get destroyed?
Yeah? Because in the eye, it knows it's there, it will attack it.
That's the immune system, it's different.
Actually, I didn't get your question. I mean, the concept,